It's critical to assess the quality of the test to be sure that you're getting the best efforts from the patients. You should be able to recognize good efforts, and you should also be able to recognize bad efforts and then tell the patient what to do to correct the mistakes that they made. A good effort includes demonstration, a deep inhalation, mouth sealed tightly around the mouthpiece, a quick start, and a complete expiration until they're empty. In the following video clip, you'll notice that the patient inhales quickly, places the mouthpiece between his teeth, closes his lips around the mouthpiece, blows out immediately without hesitation, and the technician continues to encourage him to blow out and keep blowing for at least 6 seconds, as shown by the numbers in the lower corner.
Okay, we're going to do some breathing tests, and you're going to take a big deep breath in. You're going to put the mouthpiece in past your teeth and make a tight seal, and you're going to blast all your air out.
Okay.
Okay, and it's like this. You're gonna...
Notice here that the technician explains the test, demonstrates the test, then encourages the patient to take in as deep a breath as possible and blast out quickly. She keeps encouraging the patient to blow out for at least 6 seconds.
Keep going, 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 keep going. Okay, good job.
A good test will look like this on a flow volume tracing. The flow rises immediately to a peak, then slows to a nearly straight line. This shows 3 efforts, 2 of which are larger than the third. It also shows the predicted value as a dotted line. This is a volume time tracing of the same patient. It shows that the tests all started abruptly. As time went on, the volume increases more slowly. Again, this shows several efforts as a solid line and the expected efforts as a dashed line. Here are both tracing side by side. When assessing problems with a patient, the most common one is mouthpieces not being sealed by the patient's lips. Make sure as they inhale that they close their lips tightly around the mouthpiece. You can also have incomplete inhalations, where a patient doesn't get as deep a breath in as they should. You can have slow starts where they hesitate before they start to blast out. You can have incomplete exhalations, and you can have coughing within the first second. The following video shows a patient not properly placing the mouthpiece between his teeth and closing his lips tightly.
Taking the biggest breath you can possibly take, blast it out. Keep blowing, blow, 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 blow. Keep going, keep going, keep going. You're almost there. Keep going, keep going. You're almost there. Keep going. Okay, good job.
In the instance where the mouthpiece was not sealed tightly, this results in a lower FEV1 and FVC as shown by the solid line that falls below the 2 good efforts. The dotted line is the expected values. Even with a leak, this person still exceeded the expected values. Once the patient has done this, demonstrate again with the mouthpiece so that they know how important it is to keep their lips sealed tightly around the mouthpiece. Failure to coach the patient correctly will cause them not to take as deep a breath in as they possibly can. Make sure that you tell them to inhale completely and blast out immediately. If they do not inhale completely, it will result in a lower FVC or FEV6. The upcoming clip shows an incomplete inhalation. The patient was not instructed to inhale completely, and it resulted in a lower FVC.
There you go. Blast it out. Keep blowing, keep blowing, keep going. You're almost there. Keep going, keep going, keep going. Almost there. Keep going, keep going, keep going, keep going. Good job.
Again, you will notice that the FVC is reduced in this case, as shown here. The lower solid line is the one where there was an incomplete inhalation, and the FVC and FEV1, again, are reduced in this case. A slow start commonly occurs when a patient tries to take a deep breath in and keeps trying to take a little more, but doesn't quite get it all in, and then hesitates before blowing out. In this video, you'll notice a false start. Watch as the patient takes a deep breath in, starts to blow out a little bit, and then continues to blow out after a short pause.
Okay, taking the biggest breath you can possibly take, and then blast it out as hard and as fast as you can. Blast it out. Keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. Almost there. Keep going, keep going, keep going. Okay, good job.
The volume time tracing on the top shows a scooped out pattern as the effort begins. It should rise straight up out of the baseline. The flow volume curve on the bottom shows a tracing that is rounded off and demonstrates that the patient did not start to blow out abruptly as they began their exhalation. Teach the patient one more time, demonstrate to them what you want them to do, and then have them try again. This video demonstrates what happens when a patient quits too soon. They take in a deep breath and they start to blow out but abruptly stop. If the patient does not continue to blow out for at least 6 seconds, you need to re-instruct the patient and have them try again.
Okay, big deep breath in and blast it out. Keep going, keep going, keep going, keep going. Okay, that was too short, so we're going to need to blast it out a little bit longer, okay?
Okay.
We're going to try and do 6 seconds.
Okay.
In this tracing, you'll notice when they quit too soon, the tracing drops abruptly in the flow volume tracing back down to the baseline. In the volume time tracing, it's much easier on the lower part to see that they only exhaled for 2 seconds. In this case, you need to be sure to reinforce to the patient how important it is that they continue to exhale for 6 seconds. It's not uncommon to have patients cough as they reach the end of their effort. That's an acceptable part of the maneuver. However, coughing in the first second will adversely affect the FEV1, the amount of air they exhaled in the first second. Since this is one of the 2 values that's critical for interpretation, it's not acceptable to have a cough in this part of the tracing. This video shows coughing later in the effort. You should have the patient avoid coughing if possible. In many cases, this can be avoided by having them take a drink of water between efforts.
Taking the biggest breath you can possibly take and then blast it out as hard and as fast as you can. Blast it out. Keep blowing, keep blowing. Almost there. Keep going, keep going, keep going. Almost there. Keep blowing. Good job.
This video demonstrates coughing later in the effort. This is not important as it was after the FEV1 occurred. If this continues, you can stop the testing for a moment and have the patient give the patient a drink of water. Staff errors are also a common problem. These include improper demonstration, where you don't reinforce to the patient what they're expected to do, and failure to coach during the effort. In the following video, watch as the technician forgets to demonstrate to the patient.
Okay, if you can take a deep breath in and then blast it out as hard as you can. Good job.
Be sure to demonstrate quickly each time before you have them do the test. This helps to reinforce what you're expecting them to do. In this video clip, the technician fails to use a mouthpiece to demonstrate to the patient how she expects the patient to place it in their mouth and exhale abruptly. In some cases, a patient will do exactly as they're shown and just simply place their hand up to their mouth and blow into their hand.
Okay, we're going to do some breathing tests. You're going to take a big deep breath in, and you're going to blast it out as hard as you can. You're going to keep going for about 6 seconds.
Okay.
Okay?
Another common problem is not paying attention to what the patient's doing during the test. In this case, the technician doesn't observe what the patient's doing, and again, you're going to end up with unsatisfactory results.
Okay.
One of the things that you'll also miss when you don't observe the patient is when they try to sneak in an extra breath at the end. Watch this video as the patient tries to sneak in extra breaths at the end.
Okay. Big deep breath in. Tight seal. Blast it out. Keep going, 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 keep going. Don't stop. Keep going, keep going, keep going.
Finally, try to keep the patient from bending over too much.
Okay. Big deep breath in and blast it out. Keep going, keep going, keep going, keep going, keep going, keep going, keep going. Good job.
Suboptimal effort is the most common reason for misdiagnosis. This will lead to the use of needless medications and may label somebody as diseased when they are in fact not. Technical errors in some studies have accounted for as many as 70% of the misclassifications of patient conditions. The patient session is over when you have 3 good tests and 2 of them that match. Spirometers today will indicate when you've met those goals. The FEV1 and FEV6, or the FVC, should match within 0.15 liters, or 150 milliliters. You can also quit when you've reached 8 efforts. In most cases, the patient will be unable to continue at this point or may not be able to understand. In some cases, you may want to bring in a second technician to re-instruct the patient and try the testing again. Here are some additional examples. The sawtooth pattern may be seen if a patient is closing off his throat. In these cases, you may hear a grunting noise from the patient. Make sure you demonstrate again to the patient to exhale without closing their throat. This is another example of a cough. This one affects the FEV1. As you look at the volume tracing on the bottom, you notice a kink prior to the FEV1 mark near the arrow. The flow volume curve at the top shows at least 3 different flow disturbances that are similar to the coughs indicated by the red arrows. Extra breaths at the end of an effort will create a higher than normal FEV6 or FEC. There are 3 extra breaths marked here that the patient tried to sneak in at the end. If you see extra breaths, use a nose clip to prevent the patient from inhaling. The small bump at the beginning of the flow volume loop is commonly seen when a patient has a hesitant start. To avoid this, instruct the patient to inhale completely, then exhale right away without hesitating. The volume time tracing may demonstrate a bend in the tracing. Notice that this effort does not last for 6 seconds. This causes the FVC or the FEV6 to be underestimated by about 25%. This would have caused a misdiagnosis for this patient.